Hello, 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 and welcome to another week of our topics and tips. Let's talk diabetic medications this week. So, I get so many questions about this, so I just wanted to briefly run through this in preparation for boards, how you can look at diabetic medications, what to focus in on, and some helpful mnemonics to kind of guide you through. So, three things that I always say that you should pay attention to when learning your diabetic medications is one, to know the class. Just like we do any other medications, know the classification that it falls into and group them together instead of trying to learn each individual medication. Next, know the duration of the medication, such as like the insulin, and then lastly, knowing when to use it. Okay, so those are the three things: knowing the class that it falls into, knowing the duration of the insulin, and knowing when to use it. Three things. So let's talk about that. So the three main classes of oral diabetics that you should know about, oral anti-diabetics, are your biguanides, which are first line therapy. Your biguanides is your metformin, which is also known as glucophage. And yes, I say when learning these medications, learn both the brand name as well as the generic name, so that if you see either or on boards, you are familiar with the medicines and not missing it just because of the different names utilized. Now, your biguanides are your first line therapy. So, metformin is your first line therapy. It is the big ones. That's what I think. We use the big ones first. And then I think of metformin as being, I just met you, first time meeting, metformin first line, okay? And so with metformin, we want to make sure that we tell people that, they can have GI upset, diarrhea when you take this, but to continue taking the medication and it will resolve. Making sure that we know not to give these to patients with renal or hepatic insufficiency. And you want to make sure that you're checking those LFTs while they're on this medication to be sure that they're not having any difficulty, and checking their renal function. And also a plus for this is it can cause weight loss. So you'll see that it is recommended for our obese patients as well, because it is good for that also, okay? Now, the next class is our sulfonylureas. This is an older anti-diabetic, or oral anti-diabetic, that was one of the first ones created. It's still utilized because it's inexpensive, but the issue with this is that you can have hypoglycemia with this one. With our metformin, hypoglycemia is not a big issue, but with our sulfonylureas, it is, because it has such a long half-life. Now with this one, weight gain is an issue, so make sure you pay attention to that. Also making sure that we do not give this to patients, again, with hepatic insufficiency or renal insufficiency, being sure to check their renal function and their LFTs. And again, making sure that they fully understand, just like insulins, to make sure that they're eating enough food and throughout the day, as the half-life is so long that it can cause hypoglycemia. And then our last group is our TZDs, which are like our Actose. Actose falls in this category. This one also can cause weight gain. But the one thing you do want to make sure is that you don't give these to people with heart disease or heart block, or if they have heart failure stages 3 and 4 by the NYHA classifications. So be sure that we are paying attention to that, because you do not want to give that to that population. And this falls in that category too. So people always ask me, how do you know when to use these? Again, your biguanides, your metformin, is your first line therapy. You want to use that in conjunction to lifestyle modifications such as exercise and diet changes. And then your sulfonylureas and your Actose are typically utilized after those, after your first line therapy of the metformin, if there's not any if it needs a little bit more help. So sometimes we bump up to our sulfonylurea, and then your Actose can be used with the metformin as well as the sulfonylurea. So you can use that in combination too. And so then lastly, let's talk about our insulin therapy. So insulin therapy, again, group this into classification. So we have our rapid acting insulins, we have our intermediate acting, and we have our long acting. Okay, so with our rapid acting, those end in log, like our Novolog and our Humalog, and they're rapid acting, so they cover you during your meals. So you want to make sure you're giving this when they are eating, or telling them to take it when they are eating, because it will cause hypoglycemia. It's going to reduce that during those meals, okay? So just paying attention to the peak durations on those. But again, it's rapid acting, it's a log, and so it covers them just during that meal time, okay? So during the meal. Next, we have our intermediate insulin, which is our MPH. This covers us from meal to meal. So what does that mean? So I think of it like intermediate, like an intermission. So you're at an event and you have a brief intermission, you go grab snacks because it's going to cover you through, right? So that's how I look at MPH or intermediate insulins, because it covers you from meal to meal. So it's going to cover you because the duration will carry you from like breakfast to lunch and from lunch to dinner. So it's one of those intermediate phases because it covers you during that a longer span. Again, your rapid acting is just something quick and you give it during meals because it's going to quickly affect the glucose levels, whereas the intermediate ones will cover you over a longer span from meal to meal. And then lastly, we have our long-acting insulins, which are our Lantus or Levemir, and it covers you for 24 hours. So it's long-acting, that's easy to remember. Lantus and Levemir starts with L, just like long, and it lasts all day, okay? And then last thing I want to discuss is basal versus bolus insulin, because I get this question all the time. So what is basal versus bolus insulin? So when we're starting to do our insulin, if you're having to do it either basal therapy or bolus therapy, with basal therapy, it is your background coverage, meaning that it is covering the basics and covering you all throughout the day. So that's going to be like your long-acting insulins, covering you throughout the day, okay? That's the background, covering everything in the background. You're not having to worry about it. It lasts all day. It's the basics, basal basics in the background. Whereas your bolus insulin is the ones that cover during mealtime. So like your logs, like we talked about earlier, Humalog, Novolog covers you briefly during those meals, and Brittany's Brilliance. And you know, I always say Brittany's Brilliance when I have a mnemonic or something that is helpful for this. So the way I look at bolus insulins are that, think of it like you're eating out of a bowl. So during meal, when you're eating out of the bowl, you want to give the bolus insulin, okay? So that is the way that I say to remember our diabetic management for oral antidiabetics as well as insulin, and when to give those. Remembering that we give insulin if the A1C is 10 or greater. And again, we talked about what is basal versus bolus and the different classifications. Again, remember to know your class, know the duration, and when to give it. All right, I'll see y'all guys here next week.